epilepsy surgeon at UCLA, and supposed to be doing a session with my colleague, Dr. Virendra Desai, who's an epilepsy surgeon at Children's Hospital of Los Angeles. He's running a few minutes late, so we'll get started. I've been here at Epilepsy Awareness Day for the last several years giving talks similar to this, and I understand typically there's questions, so I don't want to take too much time with the slides, but maybe just an intro for everyone, and just knowing that everyone's epilepsy journey is very unique and different. So what I'm going to talk to you about is mostly some of the generalities around the menu of options for epilepsy surgery. So treatments for sometimes include diet, specifically the ketogenic diet. But what I'm going to talk to you mostly today about is surgery, and surgery is particularly for those individuals that have drug-resistant epilepsy, so when medications fail. And this is a really important data point, comes from a landmark article that was published in the New England Journal many years ago that basically tells you that when you have epilepsy, the first medication may result in seizure freedom in 47% of patients. The second medication will achieve seizure freedom in another 13% of patients. And beyond the second medication, it is highly unlikely, it's not impossible, but highly unlikely that further medications are going to stop the seizures. So what this means is very quickly, even though we do start with medications, very quickly we can find out if a child is going to respond to medication or not. There's about 30 plus medications out there for epilepsy. The children should not be trying every one. So as soon as we know that this is not going to work, we should be thinking about surgical options. And this day and age, we have a lot of good surgical options. So this is a statement that came out, a consensus statement from the ILAE, which is the International League Against Epilepsy, which basically says epilepsy surgery evaluations are time-sensitive in children. They're going through a very critical stage of development, especially in the first 6 years of life, and there shouldn't be a delay to referring a child to a epilepsy center, a center that specializes in the evaluation and treatment surgically. The other thing to note that epilepsy surgery is not a last resort. Sometimes you may hear that, surgery is a last resort. I want to try everything before I go to surgery. But for so many of the kids that we treat and some of the conditions that we treat, we know very quickly that that may not respond to medications alone. So we got to think of surgery quite early. Also, very important here to think that, to just know that an evaluation does not mean you've decided on surgery. It basically gives you the options. So definitely try to get an evaluation as soon as possible to know what the options are for your child. What are the risks of drug-resistant seizures? So seizures obviously interfere with development. Many of the children that are untreated over time may lose developmental milestones. They may either stagnate or in certain cases they can regress in terms of their neurological development. It can affect their learning, their memory, their cognition, and so many other facets of development. We know medicines themselves, we don't know what they do to the developing brain of a young child. A lot of them are made to really slow down brain function. So you may notice sometimes that even if you get a child to be seizure-free, the side effects are just intolerable. So we want to avoid that, right? Especially, we worry about a stagnation in gain of developmental milestones, but especially when you see any regression, that becomes an emergency. And more seizures over time will damage the brain. So it's not really any one seizure, but it's the accumulation of seizures over many weeks and months and years that will cause irreversible damage. The other thing we don't talk about enough, which I think deserves a lot of attention, is it's a difficult topic, but epilepsy can kill. Epilepsy, there's a 1% risk of death with uncontrolled epilepsy per year. It doesn't sound like a lot, but when you're talking about a child, 1% per year is a lot. It adds up. So we know through numerous studies now that you reduce that risk significantly when you're having surgical treatments for epilepsy. And in cases where you cannot even cure the seizures, we talk about neuromodulation, for example, VNS, for example, vagus nerve stimulation. It reduces the risk of dying by a significant amount. So we need to think about this, and again, this is not discussed enough, but we should always be thinking about it. This is a data that came from a study done by one of our colleagues, Dr. Lamb, that showed that the 10-year survival rate for untreated epilepsy when medications was the only modality of treatment was 89%. It was higher at 92% with medication and vagus nerve stimulation, and close to 98% when epilepsy surgery was also performed. So what is epilepsy surgery? What are the menu of options? We have resective surgery where we remove a part of the brain. I don't like this word, destructive surgery, but it makes its way into several slides. But it's basically to make that part of the brain non-functional, right? It doesn't mean, so destructive surgery in that's listed here can be a cure for many kids, even though, again, we have to fix up that terminology, but that's an option. Disconnective surgery, where we disconnect the abnormal part of the brain from the normal part of the brain, and also stimulation of the brain, which we'll discuss more towards the end of this talk. So what's the goal for epilepsy surgery? Typically, there's two terms that you see thrown around. The curative, which is basically we're trying to stop seizures, so eliminate all seizures. And there's a palliative strategy. Again, I don't like the word palliative. It has, it's not the right term, but what they're trying to say is the reduction of seizures. So it's not palliation, it's not palliative care, it is just the reduction of seizures as opposed to seizure freedom. And we know that the reduction of seizures itself can also be helpful in improving quality of life and reducing seizures. And how does the surgeon access the brain? So there's typically a few ways to access the brain. There is the craniotomy, where a larger incision is made and a area of bone is elevated through which we do the surgery, and then we replace that part of the bone. You can do epilepsy surgery through a burr hole, which is a smaller hole the size of a dime, where we typically use an endoscope, which is a small camera, to do surgery, or we can sometimes do surgery in a very minimally invasive fashion through a twist drill hole, which you can see is the tip of a pencil in terms of width. And we can get to some pretty deep regions of the brain with this approach. I'm going to hand it over to Dr. Desai. You want to take over from, I think we're a few slides in.
Thank you.
Yeah.
Hi, thank you. I'm sorry, I'm very late. Just had a clinic running over, but I'll probably repeat some of the stuff that Dr. Fallah said, so maybe that'll be a good thing. So we've talked a little bit about the background of epilepsy and the surgical options that are available. Resection is one of them, and it's basically where we're just removing the bad brain, as we call it. And the goal is to remove all of the bad brain so that the seizures don't spread to the good brain and affect it from developing and functioning appropriately. So this is a good option if it's in an area that's big, it's right on the surface, it's away from any important brain. I think Dr. Fallah probably mentioned some of the results that we get from medications. So if we're not responding to medications, if you don't respond to 2, the chances that you respond to a third are about 3 or 4%, so pretty small. Resection, on the other hand, is somewhere on the order of about 60 to 80% seizure freedom, which means you never have a seizure again. So really, it can be really good odds. In that group, maybe 5 to 10% will still have some seizures, and we need to do a little more investigation. The remainder of that population has significant reduction, but might still have like one small seizure a year or something like that. So generally pretty good. What can we resect? Well, all sorts of lesions. So it's a long list here. You know, cortical dysplasia is something that's pretty common in kids that causes seizures. There are a bunch of other things. I'll focus on this last one, what we call non-lesional focal epilepsy. That basically just means that it's a normal MRI scan, and so structurally everything looks normal. What we use in those situations is EEG to guide us. So we can have an EEG that's in the brain, and it'll tell us if we're recording abnormal brain waves. And we're able to really define the borders of where the abnormal brain waves are coming from and remove that. So again, you know, what we see in this one article, they found 77% of people were seizure-free after a resection. With medicine, it's about 4%. One thing that I stress a lot to my patients, you know, yeah, a resection is a big surgery. It's a big incision. We're taking a big piece of the bone off, removing a big portion of the brain. That obviously sounds scary, and it is scary. But I think what people should compare the risk of surgery to, and the fear of that surgery is to seizures, right? So, you know, we look at this patient population, about 96% will keep seizing if they don't have that surgery. And seizures are much more harmful and much riskier than an epilepsy surgery. One other option is laser ablation. So this is a more cutting edge technique. It's pretty cool actually, so I'll show some pictures in a little bit, but what we're doing is we're making a small incision about 2 or 3 millimeters, and oftentimes we're using a robot to put a little laser fiber into the part of the brain where the seizures are coming from. And then we go down to the MRI scan, and we basically burn or treat the tissue with heat. And the way that it works is, I think of it like a sous vide, like when we're cooking something. I don't know how familiar everybody is with that. But you can cook meat, vegetables, whatever you want, at a low temperature for a very long time, or you can cook it at a high temperature for a very short time. So that same principle is what we use for this. So we have this sort of fancy software. The MRI scan is measuring the temperature of the tissue, and this fancy software is taking how long it's been at that temperature to estimate if it's been treated or not. The cool thing about this software is we can also put what we call these little checkpoints. So we can put these little markers in the tissue around where we're treating, in the normal tissue that we don't want to treat. And if it starts to heat up, it automatically shuts the laser off. So we can be very precise with this laser ablation. When we're done, we just take everything out, we put one stitch in, and patients usually go home the next day. So this is just some pictures that are showing it. So on the left side, you'll see at the bottom, it's a big, basically CT scanner that we get in the operating room. When we plan these out, we usually get a special MRI scan, and sometimes we get a special CT scan to look at the blood vessels, and we paste them together. This is before the surgery. So we can pick a starting point and an ending point and look down the whole barrel of that trajectory to make sure it's not close to any blood vessels. Once we have that plan, we come into the operating room and get another CT scan in the operating room, and then it maps all of our surgical instruments in our robot to the patient's MRI scan. The robot then just tells us where to go at what angle, and we do everything through that, which is why the risk of bleeding with this type of surgery is less than 1%. It's actually one of the safest procedures we can do. So there are other options out there. Gamma knife is just radiation. Not usually a great option in kids because it does have some effect on the normal tissue around it, but it can be an option. Embolic hemispherectomy is, again, a more cutting-edge technique. The idea is basically that we're blocking blood flow to the part of the brain that's causing the seizures. And then focused ultrasound, again, a very new modality. It's being used really right now for adults for movement disorders. There's a small group of people that are starting to use it for seizures. There's a lot that we really need to figure out on how to control this sonic energy, as we call it. But it's basically an option of treating the bad brain with ultrasound waves. So we don't have to make any incision. We're able to treat it with ultrasound. And then disconnective surgery is another option. The idea of this is we leave the bad brain in place. We just remove all of its connections to the good brain, so the seizure can't go from the bad brain to the good brain. And corpus callosotomy is one example of it. And basically what we're doing is we're cutting the connection between the left side and the right side of the brain. So sometimes seizures are starting from one side and quickly spreading to the other side. If the whole brain is seizing at once, then basically everything can shut down. What this works well for is something that we call drop attacks. So some people will have seizures where they suddenly get limp and they just fall straight down. And it happens in the matter of less than a second, so they start getting head injuries and they're in the ER a lot, having to wear a helmet. This is a good option for that. And these three pictures below is kind of showing our evolution in this technique. So we used to do a big incision, and we still do it sometimes now, but big incision, big opening in the bone, and then directly divide the corpus, the connection between the two hemispheres. Some of these newer techniques are making a much smaller incision and disconnecting with the camera. And the latest iteration is putting laser fibers in and just doing a laser ablation. So again, that would just be probably 3 or 4 little tiny incisions, just burn it in MRI scan, and then each one gets a little stitch. Usually people go home the next day. This is just showing the results of that. So it's very effective for these atonic seizures, drop attacks as we call them. About 75% seizure freedom rate from these specific types of seizures, and relatively low complication rate. Vagus nerve stimulation is another option. So the way that this works, technically nobody knows how it works, but the way that I like to describe it is that we put an electrode on the vagus nerve. It's a nerve in the neck, and we connect it to a battery that sits here underneath the collarbone. This VNS is always sending an impulse through the vagus nerve. The vagus nerve is connected to a deep control center in the brain. This control center in the brain is connected to the rest of the brain, and so it's indirectly sending an impulse to calm down the seizure activity, okay? These newer devices can actually sense the heart rate as well. So a lot of times right before we seize, our heart starts to beat real fast, and these newer generations can actually detect that and send an extra impulse when it senses that. And then the other thing that's kind of cool is that families usually can go home with a little magnet. So if you see your kid who's about to have a seizure, you can put the magnet right over the battery to send an additional impulse to try and stop that. So it could be a good option. It's really a good option if we think seizures are coming from the entire brain and we're not able to find a single area of bad brain. And the results we see are about 50% or so of patients will have a 50% reduction in their seizures. And that could be in how frequent they are or how severe they are. So we consider it something that will bring the seizures down, but not necessarily give us seizure freedom. So this is just sort of reiterating some of the things I said, and it is MRI compatible as well. So responsive neurostimulation is, it can be a great option. The way that this responsive neurostimulation works, so we call it RNS, and it's like a VNS in the sense that it's an electrode connected to a battery. But the main differences are the RNS we're putting oftentimes directly into the part of the brain that is causing the seizures. And it has a different type of mechanism. So the VNS is always on, whether we're seizing or not. The RNS, on the other hand, is only stimulating when it detects seizure activity. So it's functioning as a 24/7 EEG. It's pretty cool. You could go see the epileptologist and they can log on to the cloud and download all the information from this battery, and they can tell you, hey, your child had 10 seizures the last month, and this device aborted 8 of them. They can also fine-tune it, and they can say, okay, well, the device was actually sending a stimulation when it sensed these brain waves, but I want it to actually send a stimulation when it senses these brain waves, and really kind of fine-tune when it's stimulating, how it's stimulating, the strength of it, frequency, all of that kind of stuff. So all these different parameters the epileptologist can fine-tune to that specific patient. What we're seeing with these are usually about 80% seizure reduction, so actually fairly good in relation to the VNS. And one of the newer applications of this is actually putting the RNS device directly into the deep control center of the brain. We call it the thalamus. So the VNS, that vagus nerve, is going to connect to the thalamus and function that way, sort of an indirect modulation of it. The RNS is going to go directly in the thalamus, and so it functions the same way, but it has much better efficacy. So usually you spend a few days in the hospital. You do have to get a special MRI scan if you are going to put it into the thalamus. And then once we put it in, we usually put it in just so that it can record seizures initially. And then usually a few weeks after the surgery, we turn it on to start stimulating. And then deep brain stimulation, this is our sort of last option here. This is, again, like a VNS and like an RNS. It's an electrode connected to a battery. The deep brain stimulation typically is put into the thalamus, just like we can put the RNS device in, but it'll function a little differently because it will always be on. And the deep brain stimulation system has been around for decades. It's really been used in adults for movement disorders. And because it's worked so well, it's made its way into many different other types of disease processes. So epilepsy is one big one. And it's being more and more applied to epilepsy. And we're seeing, again, about 70 to 80% seizure reduction with this. And it works the same way when we put the RNS into the thalamus. It's the same way that the DBS works. So we put the electrode into the thalamus. The battery usually sits underneath the collarbone. It's always on, and by affecting that deep control center, it's able to calm down the entire brain. I think that's it. Yeah, that's a great question. Maybe both of us can answer that. So I'll say the theory is, and nobody really knows this, but the DBS is always on, and so we're wondering if that causes neurocognitive side effects and impacts our development. The RNS, on the other hand, because it's intermittently stimulating, we think would bypass all that. That's not really proven yet. The other things are, well, with the DBS, we have to, it's a smaller incision and just a small opening in the bone to put the electrodes in. Battery sits here, so it's a little easier to recover from. The RNS, we're usually making a big incision. The battery sits in the bone there, so just a little bit more painful, a little bit more to recover from. The risks of the surgery are pretty similar. DBS device, also that battery, because it's always on, it runs out of battery faster, so you have to replace it every 6-7 years. The RNS, again, intermittently stimulating, it lasts usually about 9 to 12 years. So those are kind of the main things.
Yeah, just wanted to add one very important note. DBS and RNS are not FDA approved currently for use in children, so it's 18 years of age and above. VNS is not FDA approved for kids lower than 4 years of age. So that's important to note because those are the very rigorous studies that you get FDA approval for, basically safety, efficacy. Now, doesn't mean you can't have it. We very frequently are implanting these devices off-label. On the pediatric side, we've done about 50 responsive neurostimulators in kids. So there's quite a bit of experience now, but it obviously needs to pass that hurdle of FDA approval as well. So that's important to note. The other thing, just personally, so I am a speaker for NeuroPace, and I provide educational lectures for neurologists and neurosurgeons, so that is important part of my disclosures. The way I think about DBS and RNS, I personally think RNS is better technology. It's made for epilepsy. DBS is adapted to, and I'll tell you why I think, again, this could be my view, but the battery life is a huge advantage. That's many less surgeries over the lifetime of that child. The fact that it's responsive, think of, if your child's having a seizure in the middle of the night, a lot of parents co-sleep with their kids because of the fear of epilepsy, and, this device is acting on that epilepsy long before anyone. The DBS can be data so they can better program the device. Those are some of the, some of the differences. Some of the bells and whistles that I think make RNS good is just having this EEG data allows you over time to better program this device specific to that child. It can help with things potentially in the future as seizure detection and sort of predicting. These are times where your child may be more prone to having seizures. The other thing that I think is super helpful, especially when we talk about our kids who are nonverbal or may not be able to express if they're having symptoms, the RNS is providing way less therapy in terms of time. So if they are, now both these devices are pretty rare for anyone to feel symptoms, like when they actually go off, when they stimulate. But in the event that child is actually feeling something, the RNS is providing less total stimulation. So that kind of gives us that. But having said that, there is no head-to-head comparison of any of these devices, VNS, RNS, DBS. I don't see anything on the horizon with like a true head-to-head study. But so for me, in my practice, I will mention DBS, but to me, it's mostly if we want to stay outside the head, VNS is a good option. But if we're going intracranially, and the risks are really just with passing the electrodes into the brain, the RNS makes more sense to me than DBS. But I think that's also very dependent on the surgeon. Some may have a preference one way or another. Yes? Yeah, so the laser ablation is typically extremely good for hypothalamic hamartomas, which is a very rare condition it's abnormality deep in the brain. That's sort of, it's basically this is the treatment of choice. Very small, deep tumors. So the smaller the lesion and the deeper it is, laser ablation is better for it. It's been used in other, cavernous malformations, which is a blood vessel abnormality. It's not as effective for cortical dysplasia and tuberous sclerosis, although there are groups doing it, and it's sort of one way to look at it is it's minimally invasive. So if we try it, it doesn't work, you don't lose the option of open surgery. But whether or not you're a candidate a lot of it has to do with the anatomy, and also how large of a lesion you're trying to make. Because if you heat up a very large volume of brain tissue, that brain tissue is going to want to expand. You know, if those cells die, they want to expand, and if it causes a lot of swelling, that's going to be problematic. So if it's, again, that's why it has to be a small target, typically a deep target. And there's folks using it now for corpus callosotomies, as was shown earlier, where sort of those are typically the most common indications. Did I miss any?
No, I'll just add that, you know, laser ablation, it definitely sounds great, right? Little tiny incision out the shave any hair, go home the next day. The downside of it is it can be difficult. The brain has all these wrinkles, and that's all the fluid around it, which dissipates a lot of the heat that's coming out of the laser fiber. So a lot of lesions won't actually respond well to the laser ablation because we're not able to get a complete treatment. So usually smaller ones, deep ones that don't have much fluid around it are good candidates. So back to, I just wanted to mention this. I wanted to caveat that he's a NeuroPace, consultant. I'm actually a Medtronic consultant, so and Medtronic usually does the DBS. Anybody from Medtronic here? Okay, good. I can say this. I completely agree with Dr. Fallah. I do think the RNS has a number of advantages. The only thing that I'll say about DBS is it came first, and it has stronger evidence to support its efficacy. So. The FDA ages? 4 years old for VNS, 18 for DBS, RNS. Well, DBS, maybe you know, so for movement disorders, you can use DBS. 12, I believe it's 12. It may be 14, and then at 12, it's a humanitarian exemption device, so, you know, we can use it. The other thing I'll say is, even though it's not FDA approved, we put in a number in kids younger than 18, quite a few. And it's really fairly simple to get it approved by insurance, so. Yeah. Yeah, it can be 1 or 2 stages, so it just depends. But you can do one stage where you put the electrodes in, and then a couple of weeks later, you can put the extension wires and the battery in. Right. Right. Sure.
Yeah, there was a question back there.
So if we're putting it deep into the thalamus, you know, these electrodes are very small, like the tip of a pencil. So it's very little tissue that it's going through, and it's not destroying it. It's typically, we'll say that it's spreading it.
What are the risks or side effects specific to the deep thalamic nuclei as opposed to like other?
Yeah, so it depends on which thalamic nucleus, I guess, we're going for. But in the thalamus, there's a lot of our sensation is running through it, and our vision fibers running through it. So you can experience some side effects with that. Usually, that's stimulation oriented. So the epileptologist can just change the stimulation parameters to try and avoid that. Yeah, so it depends on what we're coming up against. So if it's a genetic disorder where we're seeing basically the entire brain is causing the seizure activity, then we want to do something that's going to affect the entire brain. And so usually the options are vagal nerve stimulator, the deep brain stimulator, or the thalamic responsive neurostimulator. For a frontotemporal epilepsy? So it depends. What we're trying to do, I'm going to split it up this way, right? So there's two different types of seizures. There's what we call focal, and then there's generalized. And I'm sure a lot of you know this, but focal, it's, we'll see symptoms starting in one part of the body. We think that one part of the brain is causing the seizures. In those situations, if we're able to identify that area of bad brain, we could do resection, laser ablation, something like that, a disconnection. If we're not able to identify that, or we think that it's coming from both sides of the brain or a big, diffuse area, then the only options would be vagal nerve stimulator, DBS, thalamic RNS. So to answer your question, resection could be an option, laser ablation could be an option, depending on where we identify that bad brain.
You always want to be looking to resect if possible, because that's sort of the greatest improvement in quality of life. Because, typically those are situations where we can make someone seizure-free and even potentially come off medications in the long term. So there's a lot of benefits to being able to identify where the seizure is coming from and resect it. And the neuromodulation options are typically in situations where that's not an option. Either we know where it is, but we cannot safely remove that part of the brain, or multiple areas, or both sides of the brain. Those are situations where these can be helpful, and it will improve quality of life. Just the greatest improvement we see is in seizure freedom. And the other thing we didn't talk about much is children have neuroplasticity, which means the brain can rewire. That's why it's so time sensitive to do these things, because our options, we have much more options when we're dealing with a younger child than even an older child, because there are parts of the brain where you can remove in a very young child, and they'll recover those functions. But if someone's older or an adult, it doesn't work the same. The other thing I just wanted to add, you asked about the ages for RNS and DBS and VNS. The youngest child who's had a RNS is 3 years of age. And I think very similarly on DBS from what I know of. So, and even on the VNS side, as young as sort of 6 months or maybe, so we definitely will think, off-label as well whenever we have a child who's sort of having seizures and no medication's really helping. You really want to, it really becomes critical to try to treat the seizures as well as you can, as early as you can.
Great.
I'll wait up here if anyone wants to ask us anything more specific. All right. Thank you all.
Thanks for coming.